All right. So this is Phil Pugh, Director of Emergency Management here at Memorial Hospital in Belleville, and also your regional hospital coordinator and coalition chair. We're going to go ahead and get started on our COVID AAR workshop. And so thanks for everybody for joining. This will probably be meeting one of two. If we can get the majority of this done today, maybe we won't need to have a second meeting, but that's potentially the plan. This will be pretty informal. So everybody who is on, please make sure, if there's something on your chest or certain things that you felt were, as you can see on here, good, bad, or ugly, feel free to mention them. Feel free to bring them up. This is a, non-attribution environment. We want your honest and open feedback, because if we don't get that, we all can't be better. Should we continue to go through this as we are now, and things get worse, or we have something else of this magnitude occur for the state and or just our coalition specifically. As a reminder, this is being recorded. A copy of this will, after today, reside on the coalition's YouTube website. So if you go to YouTube and you haven't subscribed, please go there to get it and subscribe. And you can review it at a later date and time. And this meeting, again, because it is recorded, if you do not wish to be recorded, you can depart now and just listen, and take notes later. So let's do a quick roll call of the folks that we do have on. I will go over the folks that I know are here. We'll make sure we get that recorded. And it's weird, I can't see him now. Let's see. So we got Rick Wolf out of Gateway, Eric Perham here from Memorial and Shiloh, Lee for here, Belleville, and obviously both for the coalition. You got myself, you got Sue Laughlin out in Staunton, Kara here in St. Clair County Local Health Department, Georgia down at Memorial Hospital in Chester, and I see a few other folks without names. Also, we got Tina Evans out at Fayette County. And then I see a few folks in the chat without names that have potentially just called in. I'll give the last 4 digits of your number, and if you could sound off there. So starting with the first one at 3800. Who are you, and what agency?
This is Terry, Bond County.
Hey, gotcha, Terry. Thank you. 5692.
That would be John Nowak with MedStar. I can't get logged into the normal access.
Okay, so Lee just sent out a secondary link, and I will, if that's still not working for you, John, I can shoot you that link as well. But Lee just sent out another one to the entire coalition. So if you got access to check your email, you may see that and should get you in. Same for you, Terry. I don't know if that occurred with you, but there was something wrong with the one link. Our guys here could get onto it, but maybe the externals could not. So our apologies there.
Yes, same thing happened to me if I'm driving, so it doesn't make any difference.
Okay, you're on the road right now. Okay.
Yeah, I just tried, Phil, and I'm still not able to get onto the link.
Okay, give me one other quick second, John. I'm going to forward you a separate link that we used that helped Kara get in because she was having that issue. So I'm sending that to you now. And I'm gonna send it to you too, Terry, even though you may not need it. And there's one other individual, last 4 is 3000 that called in.
Phil, that's me, 3,798.
Yep, that is you. Okay, so I got you on 2 spots. Looks like you're on a computer and called in, but that's fine. We got you, Rick. Perfect. I'm gonna also attach this file. Just a copy. There you go. So you guys should, Terry, John, you guys should get that link and one of the 2 files that you see here. Pretty much it's the Word document. Should you choose or need to put in some notes, if you want to go back over this, you can, and we definitely would take whatever you receive, even if you don't speak up today. If you have something that you want to write down over the categories that we are covering, we'll try to capture that today. So I'm going to try to lead this as best I can. Again, very informal. and we're going to get as much data out as we can. Lee and Eric are going to also help filling out this document. I'm going to show you the results of the survey that went out. The goal, gotcha, John. All right. The goal will be to take all of the information that we have, repackage it for you guys so you can see the data in a more logical format. So there'll be some charts and everything, but it'll be weighted and a few things. And I will give you a kind of an example of what I'm talking about. For instance, for those of you who can see on the right-hand side of the screen, the coalition training priorities. So we took the information that was crunched down from your input and basically prioritize them and to show where the coalition thought we needed to focus efforts with regard to training. So this is a very concise, easy to understand chart. So that's basically weighted to what you like the most. So anything the further to the right, the better. So we'll try to make more of these in the final document, along with a lot of verbiage to go along with it, and hopefully plotting a course forward that's going to help us with certain aspects of the AAR, what we do find out in here. So with that being said, I'll entertain any questions before we get started. I know there's a lot of questions that we're going to go through. Any questions? All right. So let's go ahead and get started. So we're going to start with one of the first questions, and it was, how difficult was it to move suspected or confirmed COVID-19 patients to other facilities? And in there, it had coordinate movement of equipment and supplies. So coordinate movement of equipment and supplies is right here. It's this specific one. And let's see if I can get this all on here. That's this bottom one here. So the blue on this one is not applicable. So a lot of folks either did not have that as a need where they had to coordinate equipment and supplies. The next one is green, says somewhat easy. Then we have brown, was very easy. Then a lot of neutral, or a little bit of neutral, and some difficulty. So just looking at that objectively, it seems like things went along fairly well. So any thoughts on what were some of the good things regarding equipment and supply movement that you guys would like to discuss or make sure is captured? Good, bad, or ugly? Things where we can improve on, or that were just downright horrible. That's the ugly. And maybe something that breached potential, whether it's a law or some type of policy. That's where the ugly would reside. Bad, again, just areas where we can improve. And the good, what do you think we did good? And when I say we, I'm talking all of us together. Any feedback on that?
This is Tina.
Go ahead, Tina. I heard you say this is Tina, then you went kind of mute.
Can you hear me now?
Yep, gotcha. Loud and clear.
Sorry. So I think at
Okay.
first for us, it was a little bit trying to figure out what we needed to coordinate and where we needed to coordinate it. It would start off on a very slow slope. And then as we, into a week or a little bit more until we finally figured it out, what we needed. And I think part of ours was when the 10 arrived for us too, was the fact that now we've got to think outside the box and think we got this outside the ED and about those kind of things. Not that it was so much difficult, but it was just trying to coordinate it and try to think like we really haven't had that kind of process before.
Okay. Okay. Understandable. And are you saying that from an internal coordination of supplies? From at the organizational level or across the entire region? How are you kind of framing that?
I'm just saying from internally, but from IDPH down to the region, I thought that all that process and how that went great.
Okay. All right. How about expanding resources to support surge operations? Any bad things that we experience across the region as expanding surge operations? In here, it shows that somewhat easy was the leading category. Okay, some not applicables. I believe that's probably for either from local health departments or EMS agencies, potentially. A lot of neutral. But then we got this one here, which shows as with some difficulty, expanding resources to support surge.
Phil,
Yes.
this is Georgia. I thought that, we use resources down in this area. We always talk to our health department weekly and coordinated between the hospitals. Even some of us used tents outside, some of us didn't. We were willing to borrow and borrow and steal from each other easily. I thought that the resources, that we needed to support if there were a surge, I thought it went well. And you guys up there had the resources too for us if we requested.
So would you think, I mean, things that we think about when supporting surge, at least my perspective, I'll just say right now, I think of additional beds, being able to, if you're a hospital that was primarily single beds and, maybe you had to double up or do some cohorting of
Yeah.
patients.
We shut down our same-day surgery unit and made that an entire COVID ward. So I heard others had done that as well. That went well. That's a strength, I think.
So that was that what you're saying is a strength for you guys. So let's say that again. You said that you guys and I'll just put it as I'll put the name of who attribute this to this comment, Chester. You said that you shut down
our same-day surgery or our whole surgery department and made it a COVID ward. And it was utilized.
okay, and it was utilized. And have you guys had to do that in any other circumstances, since you've been there? Have you guys?
No, we haven't. I hope that we don't have to in the near future either.
Strengths, expanding resources, Serge. I can tell you for us, it was I'll give a little more memorial perspective. It was testy early. Really didn't, we did not have a plan, a specific plan that operated in this capacity, so to speak. Everything that we looked at for surge operations was really focused on the MCI side. So that took us some time to recalibrate. We think a lot about MCI and then ACS or alternate care site stuff, which I think that was a strength for us when we get to that area. But early on, most of what we dealt with surges was worrying about, decompressing the EDs and some of the get folks out of here a little bit early and see if we can take on a surge that's probably going to last the next 8 to 24 hours. Not something of this magnitude that was going to last. Now we ended up getting there, but that took a lot. It took a lot of planning for us to get there. So I'm gonna just say for us, I'm gonna put a little bit of a memorial. I'm gonna put an MHB in here, or what is it called? Memorial Belleville Shiloh. There we go. Memorial Hospital Belleville Shiloh for us. Our plans were MCI focused. Anyone else on expanding resources to support surge operations? I'm going to pick on John just for a minute because I know it's a little different perspective. From an EMS perspective, were there any resources required to support the additional volume that you guys experienced? I know it was kind of a lot of volume and not a lot of volume all at the same time, but did you have any resources required to support whatever COVID volume that you guys had?
Probably our biggest issue in the beginning was, of course, we were transporting. At first, everybody was accepting patients because, just like you said, nobody had a plan that this was going to go for, days, months, a year and a half. But the first probably month, we ran into the difficulty of just a lot of call volume of taking into different facilities and every facility, again, like we said, it was at the beginning. So you'd go to one facility and you were okay to do this, just bring the patient in the ER. And you'd go to another facility, and it's like, no, you stay out in your truck until we figure out where to bring you in. Literally, we were bringing in patients in through shipping areas at a couple of different facilities until things got established on where we were going to take the patients inside facilities was a big burden on us. And then something that we never anticipated. Of course, we always give our crew a little bit of time to do some disinfecting, even though we're screaming at them. We got another 911 call. But something for us that was a weakness at first was getting our dispatch to understand that we have to do a disinfecting of the truck before we take off. Again, because everything was new to us, we didn't know exactly what to do. As a couple months went on, we got that down pretty quick and easy. But man, that initial put a stomp on us. We didn't know how to respond, didn't know how to react to several of those things. But the big one was the direction on where to go at which facility, because everybody was different at first.
So say that as far as the direction of where you were going to take the patient, specifically where they were.
Yeah, because like I said, Phil, like even I'm just going to say BMH. First we were coming straight in the ER, same way with most hospitals. And then probably, 3 or 4 days into it, it's like, whoa, stay out in your truck. We're trying to figure out what our best solution is on how we're bringing in these patients. And like I said, sometimes we ended up literally pulling around to the back docks of hospitals and unloading patients there to get them to the floors that they were going to be treated in.
And
Hey, Phil.
Yes, go ahead.
So it's Lee. Hey, I've got something to go in the ugly column. It's not often I throw an ugly out, but we ran into a pretty big, significant concerning issue at a lot of the facilities with the use of the Mabus tents and conflicting instructions on take them up, take them down because of weather. A solution was provided that was a fair weather solution, and it didn't really solve the problem. It actually created more. It was mitigated later on at a lot of places by altering their structure to, like we did, to make a more solid pass through. But for those that relied on that tent, having the fire service tell us, "Oh, you got to take our tent down. You can't have that up in a storm. It's spring. It's storms."
So let's look at this. Let's pull that up a level. So the actual the actual problem was we needed to create a separate triage area for COVID, and a lot of folks are limited on space. The tent was the initial kind of go-to to do that, and then we had even problems with the tent, which were, that were potentially weather related and or weather/safety related. I'll just put safety. So ending.
And I think it's important to recognize that during that same time, we have that tent up to keep people, to reduce the number of people who are potentially in the building or potentially being exposed. But every time a wind gust comes through and Mavis sends the fire department out to take the tent down and then 4 hours later to come back to put it back up, you've now expanded the number of people that may potentially come in contact with someone they would not otherwise have. I mean, and the lack of communication that came down on when and what ones, like ours, the one at East, oh, you got to take it down. And then they came out and looked at it and said, I'm not taking that down. You got it weighted down with 16 tons. Yeah, there was a lot of lack of uniformity.
Oh, Jesus. Okay. All right. Anything else on expanding to support surge?
One of the biggest things we ran into was the labor force. Even though we tried to get staff to kind of relearn or think outside the box insofar as working in different areas, we were more successful during the vaccine portion than we were during the actual COVID run. And so we had plenty of space. We kept running into, the staffed positions every time. We get on the updating EMR resource, making sure that all of what our understanding was with respect to putting the numbers in. So it hampered us. I'm sure it hampered others, but we could have served more. We had plenty of beds. We just didn't have the staff.
So yeah, your issue again was you had plenty of space, ample space, but not enough staff to maximize the use of that space.
Correct. Early on when the National Guard was in Madison County, they asked, they said, what kind of space do you have? I said, we have plenty of space, but you're going to have to bring the labor that's going to have to take care of the patients. Other than that, I said, we're in good shape. And so it never came to that, but yeah, we were handcuffed with the lack of labor.
Got it. Yeah, I can feel you. Where are you guys currently licensed at right now?
I think their license it was 338. I think now it's like 315 or thereabouts.
And what would you say? Do you remember what the census was around that time frame?
Well, like right after COVID hit, I mean, our hospital, it's like it was a no man's land there for
Yeah,
a
it's
while.
ghost town. Yeah.
Then we started, I would say on average, we probably had 50 people, 55 people, and they were just pretty much strictly, we had a few PUIs, but predominantly in our ICU and our med surge, it was all COVID. We converted a lot of rooms to negative air. And so with that, that's pretty much where we house them. But as we started to, as this timeline started to mature, we started getting, having people shelter at home after they came in and got a test through our drive-through. If they were positive, we encouraged them to stay home unless they had some real severe difficulties. But that kind of helped us a little bit. But by and large, it filled up pretty quick.
Got it. Okay. Anyone else? Any other strengths? And by all means, again, like I said, as you can see how I'm taking the notes now, or we're getting some notes in here now, that feel free to with the document that you have, if you're writing anything down, fill those out, and we'll definitely try to pull in as much as we can. Okay. So
Hey,
expanding.
Phil, I'm
Oh, go
sorry.
ahead. No problem. Go ahead.
Hey, just underneath, I mean, I hate to say it bad, but it was just kind of to go along with what um, I kind of mentioned there, was that if we could just put something in there, the lack of communications that was pushed out from hospitals on changing. I'm trying to think of the right phrase here. Just again, I'm talking about accepting the patients, not just accepting the patients, but accepting the family members, the visitors. I think that took us a little while to get that established.
Are you looking at new policies or procedures? Is that what you're commenting on?
Well, I mean, when you're talking about even the resource or the support of surge, I mean, because it was a surge.
Yeah, and the weird part about it, I think it. Let me see if there's another spot. I'm trying to look. How to your health organization in resources and maintaining. Wondering if.
Probably by, a month and a half into it, we were getting a lot of great information then. I just think the communications wasn't very strong for the first couple of weeks. I don't think we knew what we were getting into still those first couple of weeks.
No, I think no, you're totally right, but I'm trying to look at where, and that's health department. I thought there was a spot on here that says like that talks about that level of communication to make sure that it's done. So like in here, so like I know this says training, but to me that fits under the response coordination portion, and making sure that we're effectively communicating that as an organization to our pre-hospital providers. So while every location is not going to be perfectly the same, but getting out that messaging is critical. So I'm going to put that under this part right here, the transport of COVID-19 between facilities. I'm gonna put that kind of here for now, and we'll see what we can do with it. So let's say, I'm trying to recapture all of what you just said, John. So say it again. Just give me a little bit of it again.
Sir, you're talking about somebody that's mind is gone. Yeah, the initial communications on policy changes on accepting patients and visitors. I guess you might as well throw in there I mean, we all kind of thought we had to have masks right away, but that was also something that took a little while. I mean, we initially jumped straight into PPE, but again, you were able to walk into some places without.
Hmm.
And then I'm going to throw this at you too while I got my mic open. If you want to kind of go back up to the movement, well, that was a movement of equipment. So I'll let, I don't know. Anyway, I also want to mention something about that for EMS right off the bat. Not so much for MedStar, but I know a lot of other departments, a lot of other companies had problems. I mean, we kind of all did, but uh, that hospitals replacing your gowns, man, that was like, what?
Oh yeah.
You remember all that, sir?
Yeah. I mean, the state had to kind of really came in and had to really say, hey, you need to
Yeah, so I don't know if that would have fallen in underneath your equipment and supplies, coordinating movements, and I don't know. But it
So
needs to be.
I think that would go under here, maintaining appropriate resource levels, because that's a, that was not in the calculations of most folks, right? Most
No,
folks.
not at all. Not at
Yeah.
all. And you're right. Now that I can actually see what you're putting it under, you're right. That's where it belongs. Yeah, for the hospitals for the replacement of any PPE used by EMS staff.
Do this. I'm going to slide that from bad because this is
That was ugly. It was ugly.
It's an ugly category in two regards. Again, one of the things I say for anything we put in ugly, anything that's like I know this is about COVID, so everything's about safety, but like that was weather related. What Lee's kind of talking about, somebody gets struck by lightning in the tent, was it grounded, a whole bunch of things that can go along with that. So I'm putting that there. But in this regard, this is a policy or law that maybe folks just weren't aware of, right? To the level they needed to be aware of, and didn't have that in their calculations for their day-to-day operations when it should have been all along.
Yep.
I know it's 55, blah, 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 but I think I got that. We'll make that short and sweet. Okay, thanks, John. All right. So let's go ahead and move down to the next one. Expand services beyond normal staffing. And in this one, I got a lot of not applicable somewhat easily. Some folks said they had, it was pretty easy. So I'm hoping that there are some good strengths to go along with that. And then here, our next one was with some difficulty. So what are some good things about expanding staffing for those of you who may have said that this was fairly somewhat easy? If anybody had that on theirs. Was that coming from any of our critical access hospitals, or is that from somewhere else?
This is Sue Laughlin from the hospital in Staunton.
Hey, Sue.
Hi. We had a very easy transition for staffing when we had to increase beyond our normal to staff the screening areas. We initially had 3 entry points that required screeners, and we had no problem at all getting people to work those, expanding our staffing. We utilized some of the areas that were shutting down because, the outpatient stuff, those staff members came on board to screen. And then we offered, the overtime for anybody else that wanted to sit in there. So that was no problem whatsoever. Further down the line, though, our professional staff, nursing staff, would be over there in the weaknesses. We had an exodus of several nurses to move to larger area facilities that were offering, bonuses and stuff to come on board because they were so off with their staffing that they had to offer these monetary, benefits to get people to come that were so attractive that, a handful of our staff left, and a handful is a large amount for us, So at some point in time, mid-year last year, we were in a staffing crunch and had to initiate the use of agency staff to fulfill our nursing, needs. So, it shifted halfway through the year with our nurses. Our screeners all still, because, our screeners were, a lot of them were non-licensed, entry-level staff members that were still there for us at the screening tables, but we lost a lot of nurses halfway through the year last year. That's all.
No, those great points there. Really good.
Phil, while you're typing on that with her, because she brings up a very good point that not just affected nursing or staff like that, that also affected EMS as far as paramedics. When you had the state start throwing together these contracted and offering 3 times the money to come and work for these contractors, that was a big issue at the beginning of that.
Indeed, I know. Like, we've had some folks here out of the system that went to even, went to New Jersey, went to New York, went to Texas. Left their primary gig here because they were offering so much at those locations. So were the folks that you guys lost, were they interstate, or were they, or were they all here in Illinois, just moving to other locations in Illinois, or did they like, go and then maybe never come back, went and did that and then maybe stayed somewhere else?
Well, we actually still have probably 5 or 6 that we haven't heard hide a hair of. That a couple of them went for up towards New York for some of them contracts. We still have a couple that I believe are still in the California area, but they were picked up. Like I said, you had all these different states that were offering these, bringing in these contracted services, and that they were tripling the pay. And so, it was it was difficult.
Okay.
This is Sue. We had one that left state to go to a larger populated area, but the other 4 that stepped off stepped into positions right here within our region or just across the river. We had hospitals within our region that were dangling pretty big carrots, so they stepped away. But one of them went up to Chicagoland.
Yeah, and it's unfortunate. It's like, it's weird because it's a necessary evil. It was almost like folks were transitioning to where the problem is, in the fire department, you see a lot of, just add more water, and that's what we did in those instances with staff. But that water has to come from somewhere, right? And they pulled from places like here, where at the time we probably weren't experiencing as much of the burden, again, like a New York or California were initially, and as it transitioned up to Chicagoland, as Sue's saying as well. So astute point, and I would say on the hospital side, we did see that a little bit as well. So.
Well, and the thing is that, they moved on. And now that, let's say now that the pandemic is settling a bit, they're not coming back, so they made a huge dent, like you said, adding water to that fire at another hospital just produces another fire here, and we don't have the resources. They're not coming back to, they're not returning. So that's leaving a problem that's not going away for us. Not yet.
We had some staffing problems down here due to nurses being on quarantine, or family members being positive and them being on isolation or quarantine, however. So that was hard, and those positions had to be filled by department heads until they came back.
So I'm going to ask Lee and Eric to kind of scroll on their version of this, because I think what you're talking about right now, Georgia, is on here.
It's down a little bit.
I don't know, I've seen it.
Maintain appropriate staffing levels.
Yeah. That's what. Yeah. So I'm wondering if expands, because these were expand. So I'm going to pull this one and this one. So this was down here. Maintain appropriate staff levels. So yeah, we'll move that there. And I think Rick's point should still stay in that spot. So, okay, great. So similar at Chester. So you said, so maintaining your appropriate staff levels was basically due, I'm going to say due to COVID, right? COVID related.
Yeah.
So folks getting sick.
And that's starting again now, by the way.
Hey, I'm living that right now as well. I'll tell you right now, my OC health nurse is livid because we got folks that are, maybe think they're having a sinus issue due to, the weather or pollen, whatever. But our policy is if you feel sick, don't come directly into work. Call in, get evaluated, and then let them then make a decision. So that's a big deal for us too. So staff illnesses, I'm gonna say COVID specifically, right?
Yeah, it's bad down here right now for the same reason. We have people with stomach issues calling in saying they need a COVID test, but come to find out they ate Taco Bell.
Oh, wow.
I mean, it's just ridiculous, actually.
This is Tina, and I just wanted to say for us, I don't know if anybody else had the same thing, but our incident command, because we're critical access, is so small that we were probably 4 to 6 weeks into it, and we were here on weekends and everything, that we ended up starting to rotate through because we were all getting so burned out.
Tina, and in saying that, you said, let me see, so not expanding, it's still maintaining. So you're basically talking about staff burnout now for the amount of time that you've had to do 16 different things, right?
Yes, and I'm sure other hospitals have the same thing with their incident command. You're here like 12 to 14 hours a day, 7 days a week, and after a while, we figured out that we needed to, maintain our not only our sanity, but we also needed to be healthy too to help support the facility and make decisions.
And wait, would you say that that's a cause of being both, you're those same folks that are managing the emergency still have to maintain a hospital, a, I don't want to say a regular job, right? But because managing the incident is a part of the job, but for the duration in which you had to do it. So is that accurate?
I would say that that's accurate, and I might speak. That might be the same for whether your size of a facility, Phil, or like us is critical access too.
Yeah, I can just tell you that, and Lee will probably be able to chime in that yes, we burned the candle at both ends for a very long time, and staff burnout is a real thing, truly is, truly is, and a lot of that is exacerbated by some of the things we've already said above.
Phil, I feel like that might be able to go under response as an extended response time. The incident command required rotation of positions to maintain their response efforts. It could go in the next section, not just loading all these issues into staffing, but that is a response issue also.
Indeed. I think we'll probably move it up around in that area to kind of keep a lot of this balance. Sensing command extended duration was taxed on staff and required.
And Phil, I don't know where we want to stick it, but I mean, we also had the, well, let me rephrase. I know where we want to stick it, but we had the issues with staff not just being burned out, but emotional toll from the severity of the things that they're seeing continuously.
Mhm.
We lost several folks just due to that mental breakdown.
Okay, so let's get this
Maybe not
one.
mental, emotional breakdown.
Nope, I got you. I'm tracking. So intake command staff, extended duration, taxing on staff. A few more words for this. I just put incident command, extended duration, was taxing on staff, and would that cause causing burnout?
It's fatigue.
There you go. Great word.
Yeah.
Okay. And Lee's portion was maintaining So I can put here, yeah, because we had folks just quit, and we see it all the time, right? Now you see it on the news. Maybe they quit and they come back and go somewhere else later, but we lost some good folks here. Staff fatigue led to resignations. I won't put the word quit because it's not, has a derogatory term to it. Led to resignations due to physical and emotional. Great feedback there. Great feedback. Maintain.
Hey, Phil, can I ask a question?
Sure, yeah.
So even under maintaining appropriate staffing strengths, and this goes out to the group because I'm just kind of curious because we brought it up multiple times. Since we had to reach out to agencies like temp agencies, did you guys have a good experience with getting contract nurses to come and support? Or did you feel like the temp agencies were, or these contract agencies were overwhelmed with the amount of requests that you felt, you know, that you could get maybe some nurses to come and support you, or you felt like you were pushed to the back? I'm just kind of curious because when we talk about maintaining appropriate staff levels, we do have to reach out to these agencies when our nurses are having issues. I'm just kind of curious, did you get the support you thought you should deserve?
I know for our perspective at Staunton, they jacked up their prices quite a bit. That's for one instance of a change since COVID, almost by double. The other thing is they did not have the number of RNs that we needed, and we had to alter our staffing matrix and accept the LPNs that they did have. So we have LPNs staffing what we would normally have RNs in a position because they didn't have the availability of all the RNs that we needed. So, like I said, they jacked up their prices and they didn't have the inventory that we wanted. We're still working with LPNs right now.
Okay. So Eric, if you find a spot that you want to put some of that down in here, feel free.
Yeah, that's what I'm looking for right now, Phil, because is that just you only, Sue, Georgia, or anybody else? You guys have the same issues in your locations where they're kind of staffing you with people you didn't really want or needed?
We didn't go to any staffing agencies. We just kind of did our within. The department heads actually were in those positions.
So let me, John, did we experience anything similar on the EMS side? Well, as we're talking about the kind of attributing medics or EMTs in doing any roles and responsibilities where medics would normally be doing those things? Did we have to make any adjustments?
Not with us. But I can tell you that as time went on and we were involved with several of the clinics, even with the testing and then with the vaccines, I can tell you from an EMS standpoint that when the state hired many paramedics and they hired them from anywhere and everywhere, that a lot of them had either been retired for so long they couldn't even remember what a monitor looked like, or even down to the fact that I know a couple of them was removed because a couple of situations happened and you could tell right off the bat that they had never had a medical license because they didn't know what you were talking about. That did not happen within MedStar. I can just tell you that I physically witnessed it at least 2 or 3 times at different clinics throughout the region where they were using those state paramedics that they brought in that really were not licensed medics.
Got
So
it.
I don't know where you want to put that, but that was ugly.
Lee, can you? I don't know if you want to scrub this and see if there's a spot where we want to put that, but I do want to get that. I want to get that captured some way, shape, or form, and I'd like to run that back with my other counterparts across the state, my peers across the state, and the other EMS system folks, and just ask the question: how much of that did we see? And that vetting process, because that's one of the things. Like we had to go over again our vetting process as a hospital, because we were looking at, and I don't know where we're going to put that on here, but like the Illinois helps system and how it really didn't help us during this process.
No.
So, I'm here. Maybe I put that: maintain appropriate staffing levels. I'm just going to go ahead and put that now. Phil, Illinois helps didn't help. And I did not. I don't know if I put that on. I have to figure out a way to really word that, but I don't know if that was one of the last. You know what? We did not put that on any of the training or tools, communication tools, or what have you. So, all right, but I got it here. Illinois helps did not help, and vetting process for providers from the state was
lacking for sure.
Yeah, that's what lacking. Let's go. Anyone not have any problems with staffing? I'm pretty sure that's a universal area for us in the kind of the needs or a weakness for us. But until we start maintaining or getting more and more medics and more nurses into the system, we know there's a shortage nationwide in some of those areas that we probably won't see good correction of that over.
I'm sorry. Go ahead.
We had our ups and downs down here, and we were to the point where we were able to send out nurses to our food distributors in the area to do testing, because we have a lot of Mexican Americans that don't speak English, and they couldn't understand how to get to the hospital to get tested. So we went out there all 3 shifts for a good week. So I think that would be up there on essential services to the community. That was a really high point for us.
Okay. So where do we want to put that one? Let's see. Where'd you said essential services to the community?
Yeah,
that's a section.
Did you see it up there?
Let's see. Community. Let's see.
I've got it tracked on my sheet too, Phil.
Okay.
It was just right up above.
Right above where you're at.
Yeah, right above where you were. There.
Right there.
Right here. So do you have, where are you not in the sheet, or no? Are you in a separate sheet? I saw you in here earlier.
I pulled it to my desktop.
Oh, okay.
That way, if I make notes on something, it's easier for me to jockey them around.
Okay. I want to put the.
We were helping screening as they go in there at Gilster, that we were helping them screen the people, plus we were testing. Huh?
At the factory down there, or?
Yeah. At all 3, actually. And testing.
Yeah, okay, that's what I was gonna say.
Yeah. And that kept it kept a big amount of people from coming into the hospital, because they didn't understand directions, and we had them coming in different doors with symptoms. So that reduced, I don't know how you want to word that.
A reduced hospital burden of non-English So you guys were primarily giving them, basically giving them some, screening them, trying to basically decipher, yep, it's this, that, and then, go home and quarantine, make sure, blah, 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 giving them some basic instructions on what to do.
Yeah, we made up Spanish paperwork, like we would give when we test. We did all that in Spanish and handed it out. Because some of the first deaths that we had in this area was the president of that company.
I remember, yeah.
Yeah, so.
So develop Spanish pamphlets on and 1, 2, 2. And did you worked with the health department down there?
Yes, health department and the nurse at the facility, at that facility. There's a nurse on site there too.
And she spoke Spanish?
I don't know if she does or not.
Okay, good.
The app on the phone actually helps a lot.
Nice. So you got, when you say the app on the phone, which app are you talking about? Are you talking about like Google Translate app or a different app? Okay.
Yeah.
That's a good thing, huh? Me and talk about this several times about having a translation app. That's Google.
We use that app quite often.
It just doesn't pick up slang, but it's a pretty good app.
Now, the population there, are they is this more migrant work, or are they a long-standing population? And sometimes you have migrant workers that actually end up renting or maintaining homes in 2 locations. So
yeah. Well, there's more migrant workers down in Region 5 because that's down in the orchard areas. Here, they live here long term, but they have 3 or 4 families that live in one home. So they were spreading it, pretty quickly.
Yeah.
And going to work going to work anyway, because they didn't feel that bad. And they need, they said they need to feed their family, so they're working. So we had to like hands-on keep them out. So
makes sense. Okay. So let's stay in this category. So let me just take a look here where it said maintain increased operations by focusing on essential services to the community. Somewhat easy, not applicable. Some says very easy. So this was a good area for us. So we should have other good things in this one. So.
Well, I think what I was going to say might have fallen into this category too.
What was it, or is it something we already got? Did we already capture it, or no?
No, I don't think so. Not yet.
Okay. So what do you got, John?
What due to, I don't know. Of course, we know it came down from CDC, and IDPH didn't waste any time with it. It kind of was brought up earlier, but I don't think the effects of it was quite there. Anyway, what I'm getting at is with the CDC and IDPH pushing out the essential worker and the quarantine times for when family members or even themselves were contracted with COVID, that quarantine period was hell on a lot of people, because sometimes it was 14 days or it could be 20 days, depending on what was going on within your household. So when the CDC and IDPH, if you'll remember, they pushed that out for essential workers to be able to still work. I mean, there was some stipulations to it, but it kept a lot of us still up and running because we were, the actual individual that was working was not sick, but he may have had 2 or 3 family members at home that he was, staying away from. But by the count, when the health department reaches out to you and they tell you that you're quarantined for 14 days, and then due to your son, that might be 20 days. Am I making sense? You remember any of that? I think I could still pull that up.
So John, are you saying this as a hardship or as
No, I'm saying it was a strength, because if we wouldn't have been allowed to do it, we wouldn't have had crews, or we wouldn't have had staff to be able to operate.
because I remember when that first came down, the confusion over who got to do it, and
Right.
that there were a lot of crews that were not working because they might have had an exposure. But you're talking about the part that followed on when they said, "Oh no, you can still work. You just have to do this."
Well, I'm kind of talking both, because at first, like you said, Lee, you're right. If you were known exposed, you were supposed to quarantine. Well, of course, we were being exposed almost every day. But when you actually ended up with a family member at home, or that was somebody that wasn't in healthcare, a teacher or whatever, somebody at home became COVID, you could have got thrown into a 20-day quarantine, 14 to 20-day quarantine, but we were able to still work because we were essential. We had to do a few more things like testing every time you came in shift. You had to wear a mask, you had to wear protection, even when that was a good thing, because that would have hurt us.
Okay, so
And I believe that came out of CDC first, but what I remember the most is that IDPH picked up on it right away and pushed that out to us to be able to do that. I know I got everybody confused now.
So I actually, and on my sheet, and tell me if I'm wrong here, John. I know you can't see my screen at the moment, but I tracked it as in both the good and the bad. The bad meaning that there was the initial confusion and the hardship that it created, and then once that was mitigated, it fixed the problem that it created, and in turn improved the situation.
I like it. Yes, that works. Because truly MedStar was very lucky. We didn't have our first employee with the number of exposures that we were having. Our first exposure didn't happen until almost 7 months into the COVID. So we were either doing something right, or God was on our side, or we were just extremely lucky. But we had a lot of our employees that they're poor family members.
Got it. So Lee, you captured that then.
That's correct.
Good. Okay. Good. Thanks, John. I remember it vividly, as if it was yesterday. Any other things that we could say were good, focused on the community, that were focused on the community? Anybody want to talk testing? I think that's that was I know what we had to do to get there, but go ahead, Sue.
This is Sue from Staunton. We held a testing. We helped the testing with our county through our MRC group at several of their clinics, their testing clinics. So we did do that, and then we provided the vaccination clinic.
Sorry, you were in and out. Say that one more time, Sue.
I'm sorry, we assisted the local public health department with their testing at several of their clinics through our MRC group. And then we also provided vaccination clinics for the community. Our hospital developed a drive-through testing process here at our hospital that was open 7 days a week. It still is. That's a drive-through also.
That's like Chester. We have that drive-through testing as well. Works well.
This one's probably going to be a multiple one. I'm going to say. So I'm going to say hospitals and well, hold on. Let's see. Yeah, I'm just going to say hospitals. That was I agree. This was a really really big and worked in multiple facets. I mean, we've got several. We expanded testing very rapidly in our region, and that was very key early on. So what, no, before I put that, it's just flowery words. What type of staff did you guys use? Because I will say this, we utilized our, since we dropped off the majority of the outpatient services, and, surgical cases that we were doing initially, that's where we pulled our staff from initially. Where did you guys pull your staff from?
Yeah, we took our surgery staff. Our surgery nurses they were working at the front door screening, and they also helped with testing, and then they did vaccinations as well.
Okay.
This is Tina, and what we did with our surgery staff is that several of them also helped in the ER as per diem, so we utilized them to help staff, especially to help cover when ER employees were ill with COVID or their family members.
One more time. One more time, Tina. Sorry.
It's okay. So with our surgery staff, what we did with them, there were a couple that did help as a screener, but we shut down every entryway except the main entrance for anybody to be screened, even the vendors that did arrive. And then our surgery staff, what we did with them, because several of them still have either their PRN for ER as an ER nurse, but they're full-time surgery. So they helped in the ER for staffing on both days and nights. And then that also helped us with employees who end up with COVID or the family end up with COVID and had to be quarantined.
Okay. Okay. Any other Georgia?
Hey, Phil.
Yep, go ahead.
Yeah, I got one to ask the group because I know Madison County did this, but we're talking about focusing on essential services to community. Did for the MRCs, did you guys use them to help with contact tracing? I know Madison County used their MRC to get on the phones and help, after finding, people were exposed, contacting and doing contact tracing. Did you guys do something similar?
No, we were just utilized in their testing clinics, their drive-through testing and their vaccination clinics. Whenever they were doing the vaccination drive-throughs, we were utilized there, but we weren't tracing.
That's Terry. We use our MRC in the testing clinics.
So Terry, you're let's do this. Bond County utilized, and how was that experience? What did you feel like? Did you feel like the folks came in, their skills were sharp, or they had to go? What did you have to do to get them ready to work and do that?
Actually, we had trained them before because we'd used them in our pods, so they were already trained.
But I get well, let's say they were trained, but had they been used to doing nasopharyngeal swabs and stuff like that? Because I know that's some of the issues that we ran into. While we had surgical nurses, if you have somebody who's worked in the OR for the last 20 years, sometimes they gotta, oh, I haven't done this. Now they can do it, but they had to, whether it's knock off the cobwebs to say, oh, I haven't done this in a while. Let's practice. I don't want to puncture somebody's sinus cavity or whatever. Did you have to include any other training, and did you work with the hospital or someone to fulfill or to get them where they needed to be?
Well, actually, the actual swabbing itself, our regular nurses did that.
Oh, okay. So where were those nurses from?
the health department.
Okay. All right.
Phil, I know Clinton County Health Department used theirs, and they didn't use them for any of the actual testing. What they used them for was data entry, or patient, or information sharing. And then I do know for Clinton County, they were a big part of their tracing, is making the calls.
Hmm. I want to write that. So for contact tracing, and which staff were they using?
Their MC, blah, blah, their
MRC staff?
medical core, their medical core group. We call it something different here, I think.
You say here? You saying Randolph County?
No, Clinton County.
County, sorry, that's what you said.
Yeah.
So put MRC.
Yeah, they call them something different, but it's the same thing.
Okay. All right. Any bad things in this area? Maintaining for essential services. I like to consider this the surge that wasn't a surge, and what I mean by that is that because we were so focused on MCI, like I kind of talked about earlier, that was one of our focuses. I don't think we were ready for the entire drop off of all the other things that we did. So we stopped a lot of, I'm gonna call it non-essential work. A lot of our outpatient services really slowed down. Obviously, the surgical cases slowed down. Our therapy services, or what's the right word I'm looking for? All our folks over in our rehab services, they all stopped, which left us a surplus of people. And now we have cut down on maybe some of the services that people still need. And I'm trying to figure out what's the right word for this, or right phrasing. There are things, obviously there are things that where somebody can be like, oh, I'm supposed to get my hip replaced, that can wait. But maybe there were some issues that are maybe not directly tied to a hospital or EMS, that, primary care visits or things of that nature that are more preventative. Because what we did notice in the initial onslaught of COVID is that we had a lot of folks not want to come to the hospital. I can tell you, after we had our very first patient that arrived, it was like you would have said we got cooties, and they were like, nope, gonna stay away from Memorial because they have a COVID patient. And I was like, well, you're gonna have COVID patients everywhere, you're not gonna go anywhere. And they didn't. So everybody didn't have folks going to locations. And we heard, our medical offices felt some of that as well. So as John may be able to attest to, we had folks that needed services that never took advantage of those services, that may have called 911 at some point in time, but didn't call 911 and died at home. So I don't know where that kind of goes.
Bill, I am so glad you brought that up, because I was going to say something about that too. And you are so right there, sir. Because I mean, I know myself and Chuck, we reported this all the time. If you'll remember, during that March and April and into the early July, the cardiac arrest that we had, it was just phenomenal. The numbers of cardiac arrests and that we had never experienced before. And again, in talking to family members, that's exactly why folks were too scared to go to the doctor, too scared to go to the hospital, too scared to dial 911. and we only got those 911 calls when either the patient was unconscious, unresponsive due to diabetes, or actually in cardiac arrest. I mean, if you'll remember, I could probably pull numbers up for you, but I'm not talking like 2 or 3 more than normal. I'm talking 20 or 30 more in a month of cardiac arrest. It was tough. And unfortunately, in the last 2 weeks, we have seen that same thing going on again.
Wow.
You should
And
put
not
that
just
in the
one,
ugly. That needs to be in the ugly category.
yeah, because it was ugly.
I agree with that. I totally do. That is an ugly. So and I mean so, but that's tied to something somewhere, right? This part right here, there's a reason why. I mean, is there some form of communication or education? And I don't know if that's going to be somewhere later. So I'm going to ask Lee or Eric if they can kind of scrub the list. But is that a communication piece, an education piece? And if CARE's on, yep. You know, PSAPs are going to receive, or our 911 centers, all that, they're going to receive whatever they're going to receive, right? But in order to, I can remember going on to, the St. Clair County little Facebook thing and being there. And, this was June, July of last year. I was out there, banging the table, bang, bang, bang. Please call 911 if you feel as though you need an ambulance. Do not, because we were kind of thwarting this. I don't know if that needs to be a something that's community focused. And I'm going to say health department led as far as the information sharing component and education component, because, and we're going and as to John's point, as Delta starts to go up, people are also saying, yeah, I'm not going to go to the movies, or I'm not going to go out to that restaurant, but yeah, I'm not going to go to the hospital either. So that's starting to happen again. So if there's anything that we can learn from what we did already and where we're headed back to, I think that's a key point, but it has to deal with communication. And I'm just trying to figure out where that really lies. Is that something we want to point out? Is that a local health department? Where do we want to put that?
Again, Phil, I agree with that. There was a good and an ugly to this, because I think as time went along and the education and people pushing out things like you sitting in those county Facebook meetings and the health department. And what I think was a huge plus is when our physicians and our hospitals discovered that, we could still see patients without touching them through through telemedicine.
Telemedicine, yeah.
I think that was a big plus that somewhere needs to be captured, because I think that's what did save some people, because we would get a few of those phone calls where they would say that, no, we were on the phone with the doctor and he said that we have to call 911. So that's why you're here. So again, it wasn't just it was ugly at first until that information or communications, education, whatever you want to call it, broke through. But it took it a while before it happened. But when it did, it made a huge difference.
And Phyllis Lee, I don't know that there's really a good place to put the information in there so much as it is. I think that the other big component of that is, we had the positive of the St. Louis Pandemic Task Force, but at the same time, we had the negative of the St. Louis Pandemic Task Force. It didn't, when everyone watched the news, they only talked about St. Louis. They never really talked about our side of the river, which led some to think it wasn't as bad as it was. And it led others to, again, just panic. I think a more unified message is necessary. Let's put it that way.
I'm sitting here talking and none of you can hear me. Good Lord. um, the transport, I'm going to skip a few of these and move down just in the interest of time, but I want to talk about the transport of COVID patients between facilities. I know initially, even like when we start to, if I can think of any of the Ebola training that's ever probably been done here or anything like that, I know when it started, it was a bit cumbersome. So I'm gonna lean on John quickly to get the EMS perspective on. You already talked about the location, but what were some other challenges from the EMS side of the house with regard to patient transport between facilities, taking someone from here over to Barnes or something like that?
Again, probably the big thing for us was depending on the status of the patient or the acuity of their illness at the time. O2 was a big issue, especially when you had patients that were on these extremely high flow, 35 liters or higher. I could tell you there's nothing in any ambulance around here except for now, because we literally have built one and the second one is almost done. But I don't know how many of you know what a K bottle is. A K bottle normally at a 15 liter or 25 liters will last you approximately 2 hours. You put somebody at high flow at 35, and then some of these other devices that we were using, that would suck that K bottle out in 5 to 10 minutes. That was a huge issue. Along with ventilators. MedStar carried what's called a rescue. Sorry guys, that's my wife. Hopefully she made it safely to Arkansas. But oh, now I got on hold. How did I do that?
We can hear you, John. Now you might have just muted yourself, but we can hear you. We were able to hear you.
I have a feeling I know where he was going with this, because it's the same thing we had out of a couple of our other rural hospitals where the EMS services did not have suitable ventilators for the type of requirements.
Can you hear me again, guys?
You're back, John.
Yeah, somehow reason or another, when my cell phone rang, my computer went on hold. But anyway, yes, Lee, you're correct. And so what we had to do then was we went out, of course, at the same time, we were in the middle of purchasing new monitors for our trucks. And so we voyaged out and bought new ventilators, because some of the older type of ventilators, after you used it on one patient, that ventilator had to go through days of cleaning and being disinfected. So it wasn't something that you could just use again. With these newer vents from Zoll, we were able to, due to the way they filter, and then with the extra filtering that they taught us, we were able to do some very quick cleaning on them and get them back in service right away. We tried buying and purchasing these tents that would go over the top of patients that, to try to keep that spread down. They worked pretty good, but you already got a patient that's in a panic for their life anyway. And then you're putting them in these tents, not in an isolation chamber, but it's a tent.
That's what I was saying. Not even the isopod. You're talking about just like the almost like the mosquito netting that you would probably throw around
Yeah.
from area. Like I know what you're talking about.
Exactly. Yes, you're right. And then just again the fatigue that came out of, because it's not just like your typical patient that you're taking. You get a little breather here and there. You may be able to wipe your forehead, but you had to keep constant care going, which you guys know that. You work in the hospital. You know the difference between treating a COVID patient or even a patient that's a diabetic. There's quite a bit of difference. I mean, you can't take your eye off of them. So there was some complications with that. And then, again, it falls back. I know we already captured it, but when you get to them facilities that were accepting, a lot of times they weren't ready for you. That was kind of an issue.
Got it.
Hey, John, can I put you on a spot for a second on something else that kind of...
Can I say something? Hold your thought for just a minute. For just a minute, because there is something that I have forgot twice, and I kept wanting to bring it up. I don't know where it's going to fall at on your thing, though, Phil. But this was something good that our region did, and a couple of our hospitals did. And I want to make sure that we don't lose it, because it was, I think, one of the better things that you guys did through this region. And that's when you started the ideal of coming up going, hey, we'll be the COVID spot. So instead of just always taking these patients just to every hospital, you guys made the decision, that East would get our OB and our COVID would go to you. Same way with St. Elizabeth's, they made the decision, even though we're way out in Carlisle, don't stop at Breeze, bring that patient all the way into, St. Elizabeth's. We saw that in many areas, and I think that was a huge, huge plus for our region. And I'm sorry, Eric, but I forgot to say that 3 times now, and I want to make sure that gets captured.
Well, coincidentally, when you were talking, I'm writing it down as we speak on some paper here. So just give me a second, and then I'll ask my question. Hey, John, the question I had for you was, talking about transport agencies and the transferring of COVID patients. Did you ever experience where other EMS systems would be willing to take a transfer and then realize it was a COVID patient and defer it and then put strain on you and MedStar as, taking this transfer because now you guys were able and equipped to do it? You see where I'm kind of going with this, where, people are like, hey, yeah, I'll take a transfer. I can do that. And then they show up to the ER, and then they find out it's a COVID patient. They're like, oh, we're really not expecting that. And then the hospital would have to kind of find another transport agency to pick up the slack. Did you ever feel that?
I was going to keep quiet about that, but yes, that happened all the time. And what was worse is when you would get called out to the interstate because of maybe not something that was here in this region, but something that was picked up on, Region 5 or somewhere else, and they were trying to get to St. Louis. And they didn't realize that thing that I was talking about with that oxygen and realize that they would run out of oxygen. We had that at least 4 or 5 times, probably more than that, where we actually had to meet up and take over the care and actually transport a patient, which I hate doing, from one truck to another, from one service to another to our service. They're actually out on the interstate, which I never liked. A couple of times, myself personally, I loaded a K bottle or two in the back of my truck and would take it to them. So yes, Eric, that has happened quite a bit.
Okay.
How you capture that, Phil? I don't care if you put that anywhere or not, but I wasn't going to bring that up. But yes, since Eric brought it up, I can tell you that that was a problem until these not just local services. I'm talking of even services that from different regions. That everybody was trying to do the best they could, but you got to plan. You got to know what you're capable of before you do something or attempt doing something, or it could cost somebody their life.
And yeah, I'm writing this down, Phil. So I'm just trying to capture, and then we can find a spot for it later.
Perfect. Thank you. Okay, let's go ahead and move down just a little bit. I know we've had like 2 things for resource levels, so I think let me make sure we talked about equipment. I think we've got what we need on resource levels through multiple areas, so I'm going to move past that. But this is still underneath here, so we may have to move that. I'm gonna slide past that. I'm gonna try to finish up. Were there any other things with good or ugly COVID transport between facilities? I'm gonna put this transport ventilator issue as a more of a ugly, because I put this PEEP thing here. I know we didn't say the word PEEP, but I remember going through this with good folks and other folks and making sure we had the proper amount. And I know that when the physicians and the recommendations of who needs to go on a ventilator and when they need to go on a ventilator has drastically changed from the start. I do think that initial on, we learned, I guess, initially, it was like, get them on a ventilator soon. And then that changed about 4 months into it, 3 to 4 months into having a lot of patients. And I think for the better, because I don't know, that curve kind of changed a little bit with our patients that we were losing. And obviously we brought on other things, monoclonal therapies and all that type of stuff. So, but were there any other things that regard patient transport between facilities? Were there any issues hospital to hospital that any of the hospitals could bring up or thought were problems? Oh, we can take that patient, but we can't take that patient.
Yeah, we had some trouble transferring our patients out at the, height of the pandemic when there were no beds.
Is bed availability? Is
Yeah.
that what it basically was? That in the region and out of in and out of the region, because from where you guys are at, I know you sent some folks through the Marion region to the Marion region as well. So that was.
Well, we go to St. Louis actually, so it was across the river and our region.
Okay.
Phil, this is Tina, and I will add to that. We also transferred to Springfield, Champaign, and St. Louis, of course. And then we did have a couple physicians who were from Indiana, so we got connected with Indiana hospitals. So we ended up having to actually cross the state line into Indiana for transfers.
Okay, so basically for you guys, maintaining patients for that extended duration became an issue, and then you had to reach out even further. So all the way out. I mean, for Fayette, I mean, well, I guess the difference between Fayette and Randolph going to Indiana or Indianapolis or wherever is a little different, but it's I think it's still felt nonetheless.
About a 30-minute difference, sir.
Okay. Is then the patient stay.
I think a couple of places in Indiana was like over 2.5 hours from where we are.
Okay. Over, let's just put that. Were they in Indianapolis or just in specifically or somewhere else? Or
It was Indianapolis and then also Evanston, and that's the longest ground transport was like 2 to 2.5 hours.
It's Evansville,
oh, there we go.
just FYI.
Thank you, Lee. I always get the two mixed up.
Yeah, Evanston's up in Chicagoland, right?
Yeah.
There you go. Okay.
Hey, Phil.
Yes.
I don't want to be the one keep gabbing here, but something that we do need to put in the good.
Okay.
You know, of course, again, what I really liked was after we finally got a grip on everything, the transfers, the interfacility transfers that we're talking about, the communications became strong, very strong, not only with the hospital that we were picking up from, but the hospital that we were transporting to. Uh, the communications was good. You know, like I said, probably 4 or 5 months into it, maybe even 7 months into it. And then it even got to even be better when we had hospitals saying, hey, all we got to do is meet up with so and so. They are going to direct you. Some places, like your facility was security, Barnes and SLU and Mercy and some of them, they may have used, I don't know what they were. They weren't security, but towards the end there was always somebody there to meet with us that would direct the crew right to the room, which was a great plus for us.
John, to go along with that too, the air services, they did communicate to us that they were able to transport COVID patients also.
And Tina, you said as air support became available, air transport became available for COVID patients, that helped.
Definitely, and they either emailed us, they would either call that day to make sure that we were aware that they did have service available to transport COVID patients. It didn't matter if they was in Illinois, Missouri, Indiana.
Okay, good. Now, I'm just as a quick question. When we started COVID, did we just not have a lot of folks in aircraft and helicopters transporting them just because of the environment in which they had to fly. I'm trying to remember back during that time frame. And I know we had some conversations around it here, but I just don't know what the primary reason was initially, or were they always transporting them the entire time and just didn't have, were there any issues at all, or did they always have the availability?
From what I understand from the air services that we use, I think it was just making sure they had enough and the appropriate PPE, especially in that very small confined area. And then also too, when they did transport a patient, sometimes they did ask that they also, the patient had an N95 mask on. So it's trying to work out the logistical part of how that works with fitting a patient for an N95.
Got it. Okay.
Bill, I do know that there were a couple of the agencies that just wanted to verify due to the extreme small space that they had to work within. I believe it was just a matter of leadership making some decisions for them and actually putting some new policies out for them. But I believe 90% of the time they were available and willing. They just weren't sure, and then also they weren't getting the calls. But I do know that, well, I won't mention their name. I do know still to this day, one of them that is transporting these patients, they turn off their exhaust. So or there is no exhaust at all. Their ventilation system, I should say, going on when they're transporting a COVID patient. So you can imagine how warm that gets on not just the patient, but the poor staff that's flying.
Yeah, and does the pilot and the nurse or whomever is on that bird, do they just take a small cylinder of oxygen and keep it with them too? I don't know.
Well, again, that was something that I didn't even realize until probably 5 months ago when I was sitting down with a couple of the pilots and we were gabbing about it. And he's like, I don't mind doing these COVID, but man, I'm telling you, they're rough on us because we have to shut our ventilation systems off. And so they fly, at a different altitude when they fly. But they have to stay underneath a certain scope where they can open up a window to get a little bit of a breeze. But I do know that them were some of the types of policy changes that had to be made. So, but they were always available. They just, yeah, I think we forgot about them sometimes, but they were there for us.
I get it. I get it. Okay. All right, we're running up on our time here in a little bit, so I want to scroll down to. I'm gonna scroll down to, because a lot of these are kind of doubled up in the way that they're worded. So I'm just want to roll down to this area. How effective were each of the following? And these are specific communication platforms, so we can kind of go through the good and the bad of those. Give me one quick second. Let's see. Okay, yeah. So how effective were these communication tools? So we'll start with D4H or platforms. I'm just gonna take a quick look at the data. A lot of not applicables, and then we got some good, very effectives and neutrals, and some somewhat effective. So let's just start with good, bad, and ugly with D4H. I know everybody has accounts, or 90% of folks got accounts. Kara, you'll need an account if we haven't got you one yet. But the use of it, did we consider the value add? What do we get out of it?
Well, I'll start off. I think it was very helpful once we got connected to it and knew that we were connected to it. I lived on it daily. Well, I guess you guys probably know that.
Mhm.
But I believe it was great for communications, for that quick communications. So I believe it had some value.
Okay. Anything bad about it? I mean, I try to keep a pie in the sky kind of attitude towards D4H. I would love for it to be something that we're in daily, to where we could all communicate together. But I do understand that sometimes, if you're out in Fayette, maybe that's not the thing that you're going to have up on your screen all day. Or if you're, down in Chester, it's just not what you're going to be looking at all day because you're running around doing some other stuff. But I see D4H as the common operating picture, and I would like us to. I thought we used it fairly well, especially once we kind of nailed down the resource request process. I know Rick used a lot, John, you use it. I mean, a lot of the hospitals. Once we got that down, that helped us in documenting things. We had, I don't know if I go in there and look now, 184 resource requests or something like that.
Yeah, I'll say the resource requests before we went to doing them in D4H were a nightmare because it was an emailed form, and sometimes I'd get an email, sometimes I might not, or the ones that were handwritten weren't always the most legible. And once we went to the data system, it also added some transparency because you could see the status of what was going on with your request.
And I agree with that statement 100%. But if you want something that was bad or just ugly, just because you want to fill in that column, I would say that the only thing that I would say was just getting familiar with it. But once I got familiar with it and got put in the right status where I needed to be, yes, it was a great tool.
Bill, this is Tina, and I'm sorry, but I need to leave the meeting.
I got you, Tina. No worries, no worries. We're getting close to that time anyway. So what I will say this before you bounce off, Tina, is that I'm going to, and maybe this is just a good stopping point at this point because we're here right at 2 hours. You guys have copies of this now. What I would ask you to do is just start writing, start putting pen to pad, put your thoughts in there. I will ask that once you put them in there, just send them to myself and Lee and Eric. You can just send them to us. We'll take them and start consolidating them. So now for the next meeting, we'll probably go out maybe 2 weeks. Eric, I don't know, or Lee, I don't know if we already got one on the calendar, but we will put another meeting out there for everybody to come back. I'll pull those in and we'll kind of move through it at a slightly faster rate. Then once all that's said and done, we'll consolidate all the information, and then we're just gonna try to come up with at least the actual kind of what do we need to fix. Let's take those things in the bad column and where can we look at in our plans today and repair those issues. We always love situational awareness is good, but if there's some actionable items that we can pull out of this from our lessons learned, then we want to go ahead and put those in writing and prepare ourselves for the future. This will go right along with the training exercise planning workshop that Eric is preparing. Let's see, maybe 2 or 3 weeks from now, we'll reconvene and try to finalize this and then make a full report out of it. So
can you send us what you've been typing on now? Can you send that out to us?
Oh, sure. I'll send everybody who was in here today. Sure. I'll send out what we right now. Yep.
Okay, thanks.
No problem. So anything before I leave? Anybody, guys?
Nope, it's been a pleasure. Sorry I talked too much.
No, we need that. We need that. We need squeaky wheels, John. We need squeaky wheels. I got a squeaky chair. You hear that? So squeaky wheels get the grease, man. So I appreciate any and all the feedback. I'm not ashamed to say that we suck at some things, and we'll get to those points as well through here. But we'll be better as a coalition by just being honest with ourselves. So thank you guys for all the time and effort, and we will see you soon. Take care.
Everybody have a great day. Be safe.